In addition to hearing aid users, patients who have been fitted with cochlear implants can also benefit from the aided cortical test. Performing this test on cochlear implant patients comes with some unique challenges which need to be understood and considered. The main challenge facing this cohort is the interference or radio frequency noise that can be generated by the device itself. This can be detected by the recording electrodes and lead to artifact in the waveform, which can make it difficult to accurately interpret whether a true response is present or not. There are a number of published studies detailing the use of aided cortical responses in patients fitted with cochlear implants. Cortical et al. Tested 45 children who had been unilaterally implanted with MED-EL devices. They found artifact in only 8 traces from 3 of the children tested. Of the 108 adult participants tested by Tavora Vieira and colleagues and published in 2002, there were no reported artifacts from the unilaterally implanted MED-EL devices. Another study by Tavora Vieira and colleagues, published in 2021, compared electronically evoked cortical potentials with acoustically evoked cortical potentials in unilaterally implanted adult patients using MED-EL devices. Choi et al. Reported a study of 20 participants in 2019. This adult cohort included unilateral and bilaterally implanted patients, who were all tested with just one implant switched on at a time. These participants were fitted with a combination of cochlear and advanced bionics devices, and although more artifacts were found in the AB devices, the artifacts produced by the cochlear devices were larger in amplitude. It is essential that any clinician performing the aided cortical test with implanted patients is aware of the potential for artifacts being present in the waveform, knows how to identify these, and understands the impact that such artifacts can have upon the detection and interpretation of responses. This set of waveforms was recorded from a young patient who had been fitted with a cochlear implant. There is no apparent artifact in these traces, and the morphology is very similar to that seen in hearing aid users. We can see artifacts in this set of recordings. Unfortunately, these artifacts can look quite similar to cortical responses. Key warning signs that an artifact is present is the slightly triangular or squarish shape present in the waveform. We can see the first positive inflection appears much earlier in latency than we would expect for a cortical response. Here it is just after 0 milliseconds. It is also likely to appear very quickly from the start of the recording. Unfortunately, the FMPI response detection algorithm is not able to differentiate between artifact and genuine response. And so in this case, the FMPI value was detected at over 95%, but it is not possible to be certain as to whether this was detected due to artifact, a genuine response being present, or a combination of both. It is possible to examine any suspected artifacts by removing the display filter settings. In this case, we can see how the peak has become flat and square-shaped. A true cortical response would not modify in this way. Here we can see a cortical response without artifact. When removing the high-pass filter setting in particular, there is very little change to the shape of the positive inflections. When testing patients with cochlear implants, it is important to explore these elements of the waveform to help distinguish between genuine responses and artifacts. There have been a number of studies which have looked at different methods for reducing artifacts in cortical assessments. These are summarized in a paper by Choi et al. From 2019 and largely focus on signal processing and analysis techniques. There are, however, some steps that can be taken to minimize artifact in evoked potentials recordings in the clinical test setup. The main method for minimizing the likelihood of artifact in the waveform is to reduce the chance for electrical interference from the device to be detected by the recording electrodes. The most successful way to achieve this is to simply increase the distance between the implant and the recording electrodes. This can be done by opting for a 3-electrode montage, with the reference electrode on the contralateral mastoid to the implant. For those of you familiar with EABR testing, this is the same setup. It is also possible to use a jumper cable with a 4-electrode cable collector, which effectively removes one of the electrodes from play and allows you to perform the testing with just 3 electrodes. This is easily achievable when testing a unilaterally implanted patient, and is the methodology of choice in the majority of published research papers into aided cortical testing with cochlear implants. For a bilaterally implanted patient, it is possible to explore testing with 4 electrodes and both implants switched on. But if artifact is present in the waveforms, then switching to unilateral assessment with 3 electrodes is the recommended process in these cases. A further consideration when performing the aided cortical test on patients fitted with a cochlear implant surrounds which stimulus to use. The Manu-Iru stimuli are a particularly appropriate choice for hearing aid users. This stimulus set was designed with hearing aids in mind, hence the calibration alignment with the ISTS. Furthermore, these stimuli have been validated for use with hearing aids, and data is available regarding the sensitivity of the test with these stimuli for hearing aid users from the Ladies in the Van study. However, no such data currently exists regarding cochlear implants and the likelihood of being able to detect responses when performing the aided cortical test. As such, caution is urged when interpreting the results of this test, particularly for any absent responses. For cochlear implant patients, until more data becomes available regarding the Manu-Iru stimuli, it may be more suitable to make use of the HD sounds. The majority of research papers, which have investigated cortical testing on implanted patients, have used the M, G, and T stimuli that were the predecessors to the HD sounds. The unfiltered version of the HD sounds corresponds most closely to those original stimuli. However, it is important to be aware of the poor frequency specificity of these sounds. There are research papers which propose cochlear implant programming strategies based on how the electrodes correspond to these stimuli, and have explored methods for adjusting the T and C levels. This is an exciting area for further research to build and develop the evidence base to support the clinical utility of the aided cortical test for cochlear implant patients.